So then the question is, can I still say no to certain data access and still have smart devices? Right now, there are possibilities where I say no to it, and thereby I cannot use that app anymore, or I cannot use the app to its full functionality. So if I need its full functionality, where it is really making me smart, making my life smarter, I have to compromise. That is most of the current situation in the world today, unless we take certain measures. So those need to be done is also the context of the talk. And we also must realize that already at this stage where IoT is in nascent and even artificial intelligence is in its nascent stage, we already gave a lot of authority to a lot of gadgets. They don't really know that they are controlling our lives or they are telling us things, but it's already the case. I mean, right now, for example, a simple example that we probably all of you use, I may have an alarm on my mobile phone, which kind of forces me to wake up when it is certain time, right? Not just on a mobile phone, on everything else. But I can actually, if I'm using some kind of fitness app, it actually tracks my sleep pattern, it actually tracks my wake pattern, it tracks my meetings, it tracks my appointments, everything. And that's a great comfort for me because I keep getting notifications even about this session. But how much data am I compromising to get it? It is telling me that I have to be here. It keeps reminding me, even if I snooze it, whatever, that I have to go there, do this, deliver this talk, whatever, right? So there we are already authorizing technology to take care of our life. How much are we doing that? Of course, like I said, there are good health practices. If I'm sitting for a long time and my smartwatch tells me that I have been slumbering and I should go get up, walk, and take an exercise, yeah, good to some extent. But what else is it doing? Who else is it alerting that I'm sitting for a long time? That is the question, a concern, an important concern. And then there are technology concerns, particularly where we were using internet at home and we have moved in the transformations of the society where we have put our home on the internet, literally. Particularly those who may be using thermostats such as Google Nest or something or Alexa, you know what I'm talking about. Your entire home devices, the lights, fans, or appliances that you use at home are probably connected to the internet. Your home is actually hooked. So as we move from internet at home to home at internet, what all compromises are happening is an important question. And there, in designing Internet of Things, McEwan and Casamali write, connecting the internet to the real world allows both your physical actions to be made public and in the opposite direction for events on the internet to affect your environment. That is so very true, right? With so much of news actually hitting me even when I don't want it. We are affected psychologically, mentally, emotionally, particularly in the pandemic situation. We didn't even know what to trust, what not to trust, all these kinds of mistrust issues also. Plus, if it is health data, you don't even know where all it's going, what all can happen because of the data transfer bidirectionally, and so on. So that's an important concern that we need to consider. And this is also really important. As an instrumentation engineer, I cannot really emphasize further on this than saying that sensors are not computers. A computer is acting on your behest, on your instruction when you tell it to do something. But a sensor is out there collecting data all the time. If you have a barometer or a thermometer, a room thermometer, I mean ambient temperature measurement, well, it keeps measuring whether you're looking at it or not. It is collecting data. And if it is connected to the internet, well, that data is going somewhere. That is the whole purpose of connecting it to the IoT device, right? So statistics say that in 2016, 6.4 billion devices are connected to internet. And by 2020, we're talking about 20.8 billion devices. And this was a prediction from past, so I wouldn't be surprised if this is more than that. And talking about CCTVs again, London, supposedly for high security within the city, has 4.2 million CCTV cameras, and given its population, we are talking about one camera that can monitor 14 people wherever they are. That is what we are talking about in the world, in the connected world, so to say. And so soon, very soon, we probably are not using sensors or sensor-based devices in a human world. We are probably humans living in a sensor world. That is what we will eventually be. And with so many wearable technologies coming into our hands, literally onto our hands and into our pockets, are we taking cognizance of the concerns here? That is the important, most important question. Are we developing technologies? Are we developing solutions in healthcare to ensure that we are not putting ourselves more at risk than we are benefiting from it? So the question is again, is IoT in its current form safe enough? IoT is already here, but a regulatory framework is not. And technology comes in faster and law develops slower. And I can't recollect Isaac Asimov's quote that I read only this morning, where he said, the wisdom of the society travels or develops slower than the pace of the technology that comes into the society. So that is also happening, right? So in that context, are we being responsible enough in throwing our data out, in using the data, or in interacting with the data as such? And like I said, data ownership questions are not at all answered. And a lot of times there is informed consent that is necessary, but that is a long end user license agreement. You don't even read and click accept or okay. And we don't know what exactly is happening. We need to be. And or we need to develop systems that actually ensure that our concerns as individuals are addressed by the technology we use. We'll see how also as we move through. So new protocols and standards must be developed. I'll also touch upon some of them, particularly in healthcare context. And when we are talking about legal consent, we don't really have, like I said, law moves slower than technology. So there is this GDPR, some of you may have heard about it, remember it from a couple of years back, General Data Protection Regulations in the European Union. And GDPR was developed in today's world, 2017, if I remember correctly. But GDPR, by 2018, they realized that new technologies like IoT and blockchain are irreconcilable with GDPR, or that we didn't really develop those technologies in such a way that they allow GDPR to be implemented properly. So European Union, thankfully, is one of the first subcontinents, I would say, that actually ensures that data is protected properly. And that is done very well, so very well, that a lot of IoT devices and blockchain technology devices have to be redesigning their stuff in order to be usable in Europe or European Union access. But such a thing should happen across the world. More about European Union and European Commission, where they do a lot of these things through responsible research and innovation towards the end of the talk. And with this context, let's move on to the ethics part of it. A lot of definitions, a lot of theory, a lot of philosophy, but I'll try to keep it interesting. So basics, starting with the basics, we keep hearing about morals, values, and ethics. Morals are the foundation, the fundamental baseline for ethical behavior eventually. So they are time tested, they have been trusted to be right or good for a long time over different regions. So there is not just a temporal trust in it, but a spatio-temporal trust in calling something immoral. And then they also help us to build our own character. Sometimes they may come through religion or the society around us, but essentially they are the guiding principles for life, and based on which values grow, either as positive or negative, but with a relative worth. So what is good for someone may not be good for everyone else. So that is a value. And ethics is application of those values. It is a moral philosophy at the end of the day, but it is an application of values which can be positive or negative, So the question is always, are we following the right ethics, the right ethical conduct? So in order to understand that science of conduct and go through and ensure that we have the right preparation for it is what is really, really important. So ethics, don't worry about reading the whole thing. Ethics is the fundamental character or spirit of culture, and particularly it is the underlying sentiment that informs the beliefs, customs, or practices of a group or a society. A group can be a group of people, ethnic group, or it could be a linguistic, a cultural group, or it could be a professional group, like doctors, like researchers, like educationists, anything. And the objectives of ethics include that they have to, ethics are actually, like I said, they're essentially aimed at studying human behavior and making an evaluative assessment, saying this is right, this is wrong. So they help, if we establish ethics properly, they help us form an opinion or attitude about human conduct. So ethics must actually help you systematize by establishing certain moral standards and what is right, and then defend it through judgment, saying, okay, this is right because of this reason, this is wrong because of this reason, and eventually recommend the right behavior for the for implementation or application. So, in the context of healthcare, we need to understand what moral standards or principles may be guiding in order for us to be systematizing ethics in healthcare and healthcare research and applications, and to defend why that may be right or how that can be done right, and to recommend this is what it should be in healthcare research. Empathy, which is one of the most important guiding principles, is the ability to imagine oneself in someone else's shoes and trying to feel not just for them, which would be sympathy, but feel like them, feel in their place, not along with them, but in their place. So that is when you will understand people's pain very well, very right. So the difference is between, if you see someone with a wound, with an injury, you'll probably pity them. Oh, sorry, sir, I'm sorry you're hurt. Is probably where you stop. But if you are injured, you'll probably rush to go get some kind of medication, a band-aid or some kind of ointment or something, or at least wash it under water. You don't just tell someone to wash it like you probably say if someone else is injured, right? You actually go do it yourself. That is the difference between sympathy and empathy. And that empathy is really, really very necessary as a foundation, particularly when you're talking about healthcare. And the golden rule is really very important. The golden rule of plebeians, sometimes it's called, coming from the Roman culture and the Roman Empire, but it is also a golden rule because a lot of philosophies, a lot of cultures and religions actually make that the golden rule, including Indian. And that is to say, do not do unto others what you do not want others to do unto you, or treat others like you treat yourself. That is the golden rule. If you don't want to be exposing yourself to the risks of using certain gadgets, well, don't make that gadget and throw it out to your subjects. That is the point. Or when you're using or when you're requesting a hospital to provide you data without really necessarily stripping off all the personal information or whatever, ask yourself, would you be okay if that data belongs to your family member? Probably not. If it belongs to you, probably not. So don't do it if that is not what you would do for yourself. That is really important. And then we have integrity. In Sanskrit, it's called Trikarana Shuddhi, or the three Karanas being mind, body, and words. So you're talking about actions, thoughts, and words having certain consistency. That is what Trikarana Siddhi means. Like having purity and consistency in all these three. So that must be in a generally acceptable moral standard. And for that to happen, one thing that we need to understand and really, really important is both empathy and integrity are personal choices. You have to ensure but you will choose them for yourself. So the question, as researchers and learners, is, am I choosing to be integral? Am I choosing to be empathetic in my research, in dealing with people, in dealing with people's data, in developing technology, in actually testing it out, whatever, in every phase? These are questions for ourselves. And so the next thing, or in fact, the prequel to that, the prequel to that integrity or Trikarana Siddhi is Antahkarana Siddhi. Antahkarana Siddhi is the purity is not just in the consistency of the output in terms of your thoughts or in terms of your words or actions, but it's actually the intention of your innate soul itself, the intention to do the right thing no matter what. That is called conscientiousness. And that acts as that foundation for autonomous moral concern that leads to integrity. So ask yourself, am I being conscientious and empathetic? And if you are conscientious and empathetic, well, you are also probably maintaining certain integrity in terms of research. By the way, research ethics talk about ethics about plagiarism and so on and so forth also. But here we are only concerned about ethics in healthcare domain. So don't think that the other ethics are not important. We are only talking about what is important in this context. So moving on. Moral autonomy is about being able to make an independent decision, to be able to determine for yourself what is right through critical reflection and not passive adoption, which means you're not simply following it because your organization is saying it, but you're following it because you understand why it is important for anyone to follow it. So you understand that this particular rule is important for anyone to follow, and you take it up that way and you make decisions accordingly. So that moral framework through which you can make your own decisions is called moral autonomy. And this is not necessarily against respect for authority. You actually have freedom for action through in morally autonomous ways, but within the limits that are specified by the authority. You probably have bounds of your organization that limit you, or bounds of the context that limit you, but within that limit scope, you are actually autonomous to make the right decisions. So there are a lot of ethical values that are required in this context. This is essentially about industrial technologies, but it also pretty much applies as a general thumb rule for any ethical values in a professional setting. So civic responsibility, having responsibility as a citizen towards the society also. Fairness, honesty. The meaning is on the right side, the dictionary meaning is on the right side. Honesty, integrity, mutual assistance, personal responsibility, respect for others, which is really important, particularly in a healthcare condition, where you probably know, for example, that someone is terminally ill. Would you give them the same value as someone you give with someone who has very healthy lifestyle? That is a question. Or you could be working with people who are differently able. Are you giving them the same respect as you give to quote unquote the normally able people? That in itself is an offensive word for me, but well, lack of better word, we need to define a lot that way for the languages. But anyway, so self-respect, self-restraint and control, and tolerance for diversity. All these are necessary ethical values in a professional setting, particularly even in the research context. And then trust is really important. More about trust later. I did pick the definition from a research paper, so don't necessarily have to remember it as is. A general understanding of it is okay in this context and at this stage, but it is reliance by a person or a group upon a voluntarily accepted duty on the part of another person or group. This is really important for you to understand. And it could be at different levels, in different contexts, in different societies. This is also an important understanding that one must have. And Buttrell and Cantrell say the trust has certain components, specific components of integrity, competence, consistency, loyalty, and openness. So these need to be, I mean, these are all actually measurable components. So you can quantify trust in the various contexts. In the context of research, it is really important for you to contextualize this. For example, in healthcare, the integrity that you are maintaining as a researcher in healthcare, are you telling everything that you should to your patients or to your data providers, such as hospitals or diagnostic centers or clinics? That is really important. And once you, for example, you're researching on, say, for example, risk of cardiovascular diseases based on something, some data, diabetic retinopathy, Google recently did that, right? Take an image of your cornea and predict cardiovascular diseases. Well, you actually find that there is a risk, there is an inherent risk. Would you tell that? Or would you want to keep that as a secret to yourself until, say, for example, you want to apply for a patent, which can probably take a couple of years? Or if the risk is, say, for example, fatal, if you realize certain feature of your corneal image tells, okay, this person with this corneal image has only weeks to live. Would you tell that right away, or would you want to wait until you get your patent? That is an important question, right? So such things and integrity is important really in that context. And competence, do you really have enough competence to say what you're saying is right? When you say this particular vaccine works, well, does the company have that competence towards it? That is a question. And then consistency. How good are you with consistency in terms of your actions? How reliable they are, how predictable they are, and do you have a good judgment? All this act towards your consistency rating, so to say. And loyalty. Benevolence, we'll also see that as a principle for ethics in healthcare research. Benevolence. How much do you actually protect the interests of people that rely upon you is really, really, really very important. And there is that dyad meaning two parties together. So there is an implicit promise when two persons are interacting that you won't bring harm to one another. That what you do doesn't harm the other person, that what the other person does not harm you. So in a triad or in three-person group, say for example, you as a researcher, a healthcare provider as data provider, and a patient who's actually the data subject. Even in this triad, there should be certain loyalty where you share information in a transparent manner, or you withhold information in a transparent manner. You tell why you won't probably tell certain things, right? Like stripping of patient identifiability, etc. And openness, the kind of openness that is necessary to take information from others, to consider the context that others bring into picture. You could be a very celebrated artificial intelligence engineer, but do you know enough about the medical field, about healthcare domain? If not, well, listen, you can be open, and unless you're open, they won't probably tell you everything. So give them that trust, give them that you'll be loyal, give them that you'll be integral to the data that you hold, give them that you're competent enough to act on it, give them that you'll be consistent in trying to be reliable, and then probably you'll get the data that is necessary. Same thing with patient interaction. And then you have trust. As a summary, I thought I'll tell you, sorry. So that multiple definitions can be possible. So there is no one context or one central idea for trust. There can be different definitions in different contexts and situations. And that it's conditional. There are certain specific components that are measurable. So it's not an all or none thing. In this context that we are talking about in these components, there are actually 10 more that they expanded later. Conditions for trust inventory, they call them, but they all pretty much fall into these 5 categories. So when you say someone has competence, it's not a 0 or 1 value. You're talking about probably a rating of 0 to 10 with probably even decimal points, right? So that is really important for you to understand how exactly it is conditional. When I say I trust you in terms of consistency, how much do I trust you is something I have to establish and understand and know. So that is really important, and it has different contexts, like I said, in different ways. In healthcare case, we'll see more, but there are specifics about trust when you're talking about healthcare domain and research in healthcare domain and data collected in healthcare domain. And then we have ethics coming into picture after seeing certain definitions so far, trying to set the context there. Action-oriented ethics are what are really we are really important in looking into in this case. Action-oriented ethics are ethics that actually help you take an action, to put it into practice, to apply them. They are also called applied ethics, but applied ethics is usually a broader sense that is an umbrella term that can involve other ethics, as we will see. So, applied ethics is about putting ethical knowledge into practice. So you have decision ethics, professional ethics, clinical ethics, business ethics, organizational ethics, social ethics. I can keep going on. Bioethics, medical ethics, healthcare ethics, which are all different, by the way. Or even machine ethics, robo ethics, technology ethics, cyber ethics, again, all of them different, and so on and so forth. Any ethics domain, ethics theory that can be applied, that can be modified for application, comes into applied ethics. And a theoretical classification can help at this in this context. Ethics can be descriptive or comparative. They just describe how people behave and what kind of moral standards they claim to follow. So it's about like literally seeing and describing something. I observe you and I say, oh, this person is doing this. This person is eating right now. That is a description of what you're doing right now. So similarly, this person is ethical in this context with this data in this way. Or this person is A is more ethical than B because A scored only 2 in loyalty and B scored 10 in loyalty. So these are practical ways. These are practical in the sense that we come from practical observation. But we also need to understand that they don't really tell you what exactly is right, what exactly you need to do. It is just what is being done. So you have what is called normative ethics or prescriptive ethics, where they tell you how you are supposed to be. Those are ethics theories that are prescriptive, or they give you a prescription for ethics. This is how you have to be. This is what you have to do, and so on. So these set the standards typically for a society, for an organization, for a microcosm. It could be even your family, where you set forth certain rules, right? So that is how things are expected to be done, the ideal scenario. And descriptive is the practical scenario. And for researchers particularly, you have analytic ethics or meta ethics, which actually try to reflect upon what the descriptive ethics and try to compare them with the normative ethics or prescriptive ethics and say, reverse engineering, okay, this is what it is supposed to be, but this is what people are doing, and this is probably why they are doing something else. Either they do not know or they have issues in implementing the right thing. So they are doing it this way. So meta ethics try to help you, even as a researcher, to kind of move ethics from the practical perspective closer to an ideal perspective. So you are trying to bring the ideal practice, so to say. That is what meta-ethics is. And in the context of healthcare ethics, we are really, really important to understand that with each device, with each iteration of the solution, not device, with each iteration of a solution, you also ensure that you're not just giving better accuracy technologically, but you're also moving towards better ideal ethically. So that is really important. And there are certain what we call duty ethics or deontological ethics. Ontology refers to existence, and deontology is of existence, or you are supposed to be doing certain things as your duty because you exist with a certain identity. There are various duty ethics given by various people. We have seen some of them here. Immanuel Kant, who is taken as the father of deontological ethics, says there must be a universalizable maxim, which is typically a moral rule, which drives the action. And it has to be in accordance to principles that govern duty. Without getting into too much detail there, Kant says there are what are called categorical imperatives. So when I say killing is wrong, it's immoral. Well, there is a moral rule against killing people. As simple as that, a universalizable maxim. But the maxim itself is not complete because the duty of, say, for example, military people or hitmen requires that they kill people. So they have a duty to kill people, and killing is wrong. So how do you bring the balance? There, Kant asks, is the action in accordance to the principles that govern the duty? So your duty says you have to kill. So the maxim that is really universalizable is not just killing is wrong, but really killing is wrong if it is not required by your profession. That is what it is. The same applies to mercy killing, euthanasia. If a patient or the patient's family members, in case the patient himself or herself is incapacitated, they can actually request mercy killing. So that is allowable because the universalizable maxim says you can kill if and only if there are certain prospects or certain aspects that define your duty that way. And then Ross says, or W.D. Ross, duty ethics says that you have a prima facie duty, which you know by intuition. I won't get into the details, but he has listed 8 different components, 8 different categories of prima facie duties that can come into picture. That drive intuition. Though I do not get to the details, the listing of the 8, it's very interesting and important to note that the 4 ethical principles or 5 ethical principles here come directly from process ethics. Well, Kant sets the foundations, is the father of deontological ethics, and Ross and Rawls followed them in the subsequent centuries. So 18, 19, and 20. So we have these different duty ethics coming into picture, and health care ethics are defined primarily based on Ross. And then John Rawls said, it is ethical if the action is based on maximum equality or consensus regarding inequality. It's kind of easy to understand if I say, if I give example of a reservation system, or probably, for example, maternity leaves. Well, maternity leaves are not available for everyone, right? They're only available to pregnant ladies, either pre or post pregnancy, depending on the organization and the country you live in. But they're not really equally available for everyone. But there is a consensus that only they require that kind of leave. So there is an inequality, but there is a consensus about the inequality. So according to John Rawls, that is okay. But in all other contexts, the equality is maximized. It's not just that everyone has equal, but John Rawls also talks about maximizing that equality. Or in other words, if you're talking about 100% availability of any resource, everyone getting 10% is okay if there are 10 people. But if there are only 5 people, everyone should be getting 20% in order for maximum equality. It's not just 10% anymore, because the equality is supposed to be maximum also. So in the context of healthcare, we need to understand that whatever is available to certain groups of people is available to everyone in that group of people, accessible to everyone, that they have that kind of equality in that. And if there are marginalized sections, say for example, we are talking about the vaccine, right? The COVID-19 vaccine. The first vaccines would be given to frontline warriors once they are finalized, is what most countries already declared, because they are at higher risk. They really require it better than you and me sitting in our own homes or probably working from our own offices with limited mobility. But they're actually exposing themselves to risk so that everyone else can get benefited. So there is a consensus regarding that inequality that comes here. By the way, I'm not really looking at the chat box or the question and answers. So I request the organizers, should we take all of them at the end, or do you wish to interrupt me or take the questions in the middle? Either way is okay.
We would take the questions at the end, sir.
Okay, great, sure. Okay, please keep a tab on the questions and ensure that you'll ask at least all the relevant questions without repeating them, but thank you for that. So,
Sure, sir.
we talked about the duty theories, and now we'll talk about the rights theories. It is also important to protect rights, particularly in the human rights context of healthcare, right? So, there is a protective barrier. Right is an entitlement by definition. So, there can be certain unjustified moral infringement if you don't really have protection for rights. If I can simply say, doctors are expected to protect people so they can do whatever. They can probably actually inject a virus into me just to find a cure for it. I don't have access to an actually diseased person, so I inject the virus into you and I find a cure. That is for the greater good, right? Well, unfortunately, now today we know that it is ridiculous. But it took us until the 1860s for someone to say it out loud. There is this doctor, a scientist, a medical researcher, who, Sanally, if I remember correctly, who claimed in the benefit of medicine that he actually injected yellow fever virus into 5 subjects, humans. And it took like about 20 or 30 years later that someone else actually pointed outright, very clearly stating, it is not just ridiculous to know that a particular virus is toxic and can be fatal to health and injected, it is actually criminal. It was not until the early 20th century that people could actually speak about it. Before that, well, they just could give informed consent, all this. I didn't really want to bore people with the history part of it, but on ethics and healthcare, I would say it was not until 17th century that anyone talked about anything like that. It was not until 18th century that anyone talked about informed consent, getting informed consent from people. And it was not until 19th century before we actually formed those lines that say, okay, this is definitely no, and this is okay. And it was not until the 20th century, actually until the mid 20th century, or even post mid 20th century, we are talking about 60s and 70s, 1960s and 1970s, before a lot of these principles came into practice, before these principles were laid out, saying, okay, this is what it must be. In fact, the guiding documents, policies and protocols followed even by the National Institute of Health in USA or given by the World Health Organization or various organizations in the world that look into health, they were revised even as early, as latest as 2015 or 2016. And of course, even the COVID, that required a lot of revision in terms of accelerating and expediting the vaccines to be getting out, right? But in fact, the guiding principles themselves, the foundational principles, were given in 1964, but they were revised 5 times before 2000. So this is an evolving field that is also very important for researchers to note, that this field is evolving. So what I tell today may be entirely out of context 3 years later, if new rules come into picture, if things change, if technology is catching up faster than law can. There can be a lot of things, but understand that human rights must be the moral bottom line. Whatever it is, I cannot violate human lives. I cannot violate human liberty, human equality, and so on. And Immanuel Kant, who gave the duties theory or deontological theory, also his basis was respect for autonomy. He said, even in the past, that if I require to do certain thing by my duty, autonomously, I would probably be doing it. That is what he respected when he said categorical imperative that is to be followed. But he also says there must be a respect for autonomy in terms of rights, particularly when I am signing up a human subject for healthcare research. Well, I need to understand that I am giving them enough information and that they are willfully getting into the contract, a non-disclosure agreement they are signing for me, with clear understanding of what it can mean to them, their family, their social image, their cultural aspects, everything. That needs to be clearly protected if I am involving human subjects. And John Locke said, action must respect everyone's moral rights. And it was John Locke, because of John Locke, that the American Constitution that was enacted in 1776, in 18th century, of course, included the words liberty, equality, and pursuit of happiness. So that came into picture there because he said it is in everyone's moral right to have one's own protection for liberty, equality, and pursuit of happiness. And with Abraham Milton, who came by the next century, he said it's not just about liberty, equality, and pursuit of happiness, but it's life, health, liberty, and even property. Well, in the later 20th century, we even extended that property to intellectual property, which protects a lot of researchers' rights. But these are all about protecting rights. In the human context, this is really important to ensure that organizations or your research funding organizations, do not come above the human subjects that you may be dealing with, above the data that may be pertaining to individuals. There are certain human rights that you need to actually follow and respect as the golden rule that you will not violate in any case. And so the human rights that I said include first that the rights are natural, that they're not really or not all rights are given by government. Of course, fundamental rights are listed in the Constitution, but there are also natural rights that I have as human being. Thankfully, courts actually uphold that sometimes. In this context, I am reminded of a kind of unrelated thing, but in the context, Apple phones allow this pinch zoom, right? You can zoom by moving your fingers apart on the screen, or answer a phone by sliding your finger right or left or up or down, wherever, depending on what phone you're using. This action, Apple tried to patent, saying that this is how their technology works, and the court said that is a natural human right, and you cannot simply patent the act of spreading your fingers across, right? So that kind of rights must be protected. They are natural. They are not necessarily given to us by government, and they are universal. They are equal for everyone, and they are also inalienable. In this context, that's not really very worth, so I'll put that aside. But there is also welfare rights, which are important in this context. Rights to benefit the needy for a decent human life. This is really important, that you ensure that you are not compromising on the welfare rights of people who are complying with your testing methodology or giving you data, so to say, in healthcare research. And then one foundational theory that I prefer strongly recommending is Aristotelianism, given by, of course, Aristotle, or what is called virtue theory. Virtue theory says that it's not about ethics of conduct, it's ethics of character that is really important. You need to develop the right character, and that character will eventually prescribe what duties you will have and what rights you can get. And so Aristotle recommends and prescribes that you have to be a virtuous agent in yourself by balancing the extremes of conduct, emotion, desires, and attitudes. So he says a golden mean between the extremes of excess and deficiency need to be attained. This is really, really very important in the context of research, in the context of healthcare research. Say, for example, we'll read more about it later, but informed consent. There can be great benefit that I can do if I don't inform my people, and I can still do the research. And there can be an important necessary requirement that I have to tell everyone. But there is probably no way that I can reach out to people because, well, I don't even know whose data I have. So where do I have this excess and deficiency of information? Where do I strike that balance and arrive at that golden mean? So similarly, when you say development and when you say protectionism towards environment, where do you strike that balance that you call sustainable development? That is the golden mean that you need to achieve according to Aristotle, and that is really important. And McIntyre says, do what can be achieved with what can achieve common good and social good. This is really important in terms of justice, health, safety, and usefulness. And then we have the justice or fairness theory. Pretty much Rawls' theory that I spoke about about maximum equality or consensus about inequality is really about justice and fairness here. Justice and fairness are two different things really, but in the context of healthcare ethics, they are used interchangeably. Equals must be treated equally and unequals unequally, is what Aristotle said, and that is the basis for justice and fairness theory also. So, like I said, the doctors or nurses or healthcare workers of all kinds, or even public workers who are exposed to COVID affected patients, for example, in the current context of pandemic, they are unequal because they have higher risk. So the equals must be treated equally, but the unequals must be treated unequally. There have to be special provisions for them. They probably need a 95 mask where you and I can probably simply walk through with a cloth mask. There are special requirements for them and special benefits that must be given, and only that is fair. So fairness is not about equality. Fairness is about inequality where it is really necessary. And when a moral is being applied, is it being applied fairly? When you say, for example, that informed consent is definitely necessary, well, if you cannot reach out to crores of population, you cannot do it anymore. So, are you really implementing it in the right sense? It is a moral. It's a good practice, medical practice also, for to get informed consent. But there are also exceptions because it is not practicable to get all that. So that exception will ensure that you're doing it in a fair manner and that you're not being unjust in trying to get that. So you ensure that there is no unfair practice and that there is no discrimination. So a discrimination or bias could be ensuring that only a certain set of people will be benefited better than the others. So if they are not unequal, they should not get that. Say, for example, a common notion that we also saw and we probably equipped in our daily conversations, that after the healthcare professionals, probably the military and frontline workers, frontline warriors, so to say, well, probably it's the politicians who will get the best benefit. Those are the ones who will probably be vaccinated first. Well, probably true, but is that right? Can they be benefited for a justifiable reason? Are they being benefited because they are taking it in public like Obama or Joe Biden did in the US, just so that they can instill some confidence among people? Or are they doing it at the cost of people getting the benefits? If there is only one dose of vaccination, should I get it or should the Prime Minister of India get it? That is the question. So it cannot be favoritism. Favoritism may not be applied or bias may not be applied just because that person is a VIP. So this is really important. And then there should not be discrimination also, that some people may be led to die or suffer while others are benefited. Particularly in healthcare and clinical research mainly, if the group that is subjected to certain test or diagnostic, if they are going to suffer certain loss, that has to be compensated in some way, with information to them, of course. So justice and fairness must be inherently considered in case of ethical theories. I believe I'm running too slow. We are only until 1:15, right?
Yes, sir.
Okay, I'll quickly pass through and probably answer questions through for the remaining thing. Sorry. So ethical principles of healthcare are based on essentially the first four principles, but there is a fifth one added sometime. So I thought I'll put that there. Autonomy, beneficence, fidelity, justice, and paternalism. Fidelity is sometimes replaced with non-malfeasance, which also comes from Ross's theory. So autonomy, beneficence, non-malfeasance, and justice directly come from Ross due to deontological ethics. So autonomy is that the patient typically has the autonomy to make a decision whether or not to participate in a certain study. They have typically the decision, decisive authority to tell whether or not they want to share their data with any research organization or researcher. Beneficence is about ensuring that the benefit reaches to the maximum. Non-maleficence is about whatever, above all, do no harm. That is what directly comes from the Hippocratic Oath, which is kind of the basis for medicine. Father of modern medicine, Hippocrates is called, and Hippocrates. Hippocrates' oath says non-maleficence, or above all, do no harm. You probably can do benefit, but at least don't harm. And justice, ensuring, we talked about justice already. Paternalism is being a father, literally. So, can you impose paternalism? Can you say, you don't even know you are the patient? I'm a medically trained doctor or a sister. I have like 10 years experience, so listen to me. Or can you still consider the autonomy? So there is a conflict between autonomy and paternalism. In some cases, where the patient or the family of the patient do not have the knowledge, awareness, or the capacity to make a decision, then you may apply a certain level of weak paternalism in order to take and make an ethical decision. So, quickly moving on. Research can be observational or qualitative research methods, which are typical for social research, but are also considerable in healthcare research. And of course, scientific research is experimental, most of it, or interventional. And there is what is called a whole concept of comparative effectiveness research, or CER, where you compare with the control groups, cohort groups, and so on, and do it. And there is responsible research and innovation, which I wanted to speak about, and I will hurry up a bit. So, there are challenges in healthcare research in terms of scarcity of accessible data for the researchers, confirmation bias, which essentially means, am I finding what I'm looking for because I'm looking for it, or am I finding it because it is out there? And there is an is or can versus ought or must. So, is it right just because I can do it, or should I do it? Must I do it? Is a question. That is an important question in healthcare research when I'm using data, when I'm probably exposing certain aspects of the data, etc. And threats to moral autonomy in this context include appraisals or reviews, time schedules, fear of competition, or the management's attitude. So, like I said, in the context of the vaccine, did we review enough? In the time schedule we have, did we just release the vaccine? Like, for example, the Russian vaccine, Sputnik V or Sputnik 5 came out without really conducting the phase 3 is what was heard. So, due to the time schedule, did we actually cut down on the diagnostic tests that are necessary? Or unlike that, Moderna, or AstraZeneca, or Pfizer, BioNTech, they are doing research all through 4 phases. I mean, the 3 phases. Even Bharat Biotech is doing it that way. So, are we compromising or are we expediting? That is the question. Or it could sometimes be your organization or the funding agency's attitude to wrap it up fast. Or it probably is the fear of competition in the context of research about publishing sooner, getting a patent sooner. Are you rushing through your research without giving due diligence and due care to individuals' rights and responsibilities is the question that we need to consider. This I'll skip. And for others, this is actually episode 9 of season 1 in the Big Bang Theory, which is a TV series, and the YouTube link is up there. Episode 9, season 1, you can search for it, where they demonstrate Internet of Things at its rudimentary level. So responsible research and innovation is coming from the European Union as an approach that anticipates and assesses potential implications and societal expectations with regard to research and innovation, with the aim to foster the design of inclusive and sustainable research and innovation. This, every keyword is really important. We'll look at it in the context of health in a bit. So moral dilemmas can come from various reasons. The word dilemma essentially means that there is a vagueness or conflicting reason where you have more than one path that may be right or more than one imperfect solution. So how do you do it? And it could be in healthcare. The dilemmas can be interpersonal between the patient and therapist, or you are a researcher, that could be the case also. It could be intrapersonal, where you are not sure as a researcher what you should be doing or what you should not, or even for the patient. Should you tell the patient about certain risk that you suddenly identify through research? Do you have enough trust in your research that you should divulge about it already? Interprofessional between organizations that are exchanging data and such, or intra-organizational within your organization. Should you tell everyone about the data and findings, etc.? Or there could be other socio-political and health-related issues that we are talking about. And there are ways to resolve ethical or moral dilemmas by identifying moral factors and reasons, collecting information, data, and ranking your options, and then making a systematic approach through decision trees and matrices discussing with the experts in the field and so on, and finally settling down for a satisfactory, if not an ideal solution. These are all really very important. So there are normative, conceptual, and factual ethics, ethical inquiries, where you try to understand how something is supposed to be done, what exactly you're doing, why, whatever you're doing, and what exactly is being done, and put it in context. Try to picture your ethical decision-making framework accordingly, and create a framework for it based on the questions that you need to ask. You definitely need to ask in order to understand what, and then how, and then what exactly was done, how can you do it better. So there can be prescriptive decision making where you say this is how it must be done optimally, or descriptive decision making where you observe how people are making decisions and you create decision making strategies accordingly. So there are various decision making methods. I'll skip for the context of time. In the context of time, there are go for and decide or standard steps. You can look up Wikipedia decision making and you can find these, where you start with certain goals, options, facts, effects, and review them, and so on, make a decision accordingly. And when you are approaching ethical issues or concerns, you consider the fact that there are contributions from various aspects. There are ethical theories, there is technology, there is methodology, there is a recommendation, and there is other contribution that can give you new insight. So all these must be considered in every ethical concern before you take a decision in your research. And these are, I don't know how much time, can I overshoot a little?
If there's a little more you can cover, it's up to you, sir. It's fine.
Like 5-10 minutes?
5 minutes, okay.
10 minutes is okay?
Okay, sir. Okay, no problem.
Thank you, sir. Thank you, ma'am. Thank you, Darshan. So, 8 ethical requirements include collaborative partnership, social and clinical values, scientific validity, subject selection, favorable risk-benefit ratio, independent review, informed consent, and respect for potential and enrolled human subjects, according to the National Institute of Health in USA, but pretty much applicable anywhere in the world. It may be noted that National Institute of Health does not really talk about the first one, but it sources all these from Mr. Dr. Lawrence Emanuel, who gave 8 requirements. So the collaborative partnership says you must involve community advisory boards, patient advocates, and also advocates of research funding in order to make a decision ethically. That there should be a social value in the sense that whatever you're doing must lead to advancement of generalizable knowledge and or improvement in the health of participants, and the clinical value that NIH says is about improving the medical profession also in some way, like introducing a new way to do things. It's not just about health of participants, but it's about improving the technology or the methodology on the clinical end also. So a social and clinical value. And scientific validity, where you produce reliable and valid data that can be interpreted, and you choose proper studies and don't really end up with confirmation biases, etc. That you actually carry out statistical tests properly, and you have enough subjects to make a reasonable conclusion. And a fair subject selection, where you ensure that you select your subjects based on the scientific objectives and not just because you can get away with it. As in, you don't really just give the vaccine to, for example, homeless people just because no one cares about them. They are not accounted for in the census or anything. You actually do it with a scientific objective, not with discrimination, not choosing people from a vulnerable or privileged group. So you don't really pick the rich people, high influence people, or the high risk people, where they may be subjected to, with comorbidities. If you're testing out a vaccine, they will probably die, and you don't know if they actually died because they had diabetes or because the vaccine didn't work. So the fair subject selection ensures that you don't really pick them through your conveniences, but you pick them with respect to the scientific objectives. And of course, it also must include any targeted populations. For example, whatever is happening with the kidney disease in Srikakulam district, or with the water contamination recently in Yellow, those are targeted populations that you may have to conduct tests on. So your subject selection must be taking that consideration also. And independent reviews are necessary to avoid conflict of interest, because as a researcher, you probably have multiple objectives, which are all legitimate, which are all right. But there can be conflict of interest between you as a researcher, between the hospital that provides you data, and the people that are giving the data. So conflict of interest must be avoided. And also we need to ensure that the society is benefited, not at the risk of abusing subjects. So it's not like you just test out a vaccine and say, okay, all these 10 people died, so we'll not test this vaccine for them, right? That can't be the case. And so there must be an independent review. And that is why later in various countries, including India, we have what are called IRBs, or institutional review boards, and ethical committees and research ethics committees that actually oversee the whole process before they permit the use of data outside the domain of healthcare and medicine. And informed consent is necessary. I'll go a little detail on that. So to protect confidentiality, to permit withdrawal of people providing information, to provide new information, to monitor welfare by actually reaching out to the person giving the data sometimes, and informing them of what we learn through the research. Informed consent is definitely necessary for them to be able to autonomously make a decision whether to give their data or not. Even if you are signing up an MOU with a hospital, unless the hospital signs a similar informed consent form with its patients, they cannot give the data to you. That is actually why researchers in healthcare already probably know it's tough to get data, because there are multiple layers of permissions and approval that even the hospitals need to get before they can hand over the data to us researchers. So informed consent requires competence of the subject, that they can understand and they have awareness about what they are understanding or listening, disclosure of information in terms that they will understand and comprehend, and voluntariness in making the decision. And in USA, the informed consent form includes these eight elements, definitely, that they understand before they sign. These 8 things are aware, they are made aware to them. Purpose and duration of participation, the risks involved, the alternatives available, why they must anyway participate, though they are alternatives, benefits that come out of it to the world, to them maybe, confidentiality of records, to them could be even an insurance benefit, right? So confidentiality of records, how you are actually protecting the records, compensation for injuries that they may be encountering in the process, even if it's just a needle point, right? What exactly they are undergoing. Person to contact for answers to questions if they have any. At some point, if they develop, say, for example, fever, why exactly, what exactly, things like that. And voluntariness and right to withdraw. All these must be in the form of informed consent co-signed by the participants. Otherwise, you should not conduct the data research. And like I said, if the hospitals don't do such a thing, an equivalent of it in India, they cannot give you data also. So there are other ethical requirements. That is one important thing, so I focus more on that. But there is fair risk-benefit ratio, where you ensure that there is fair amount of benefit to the risk that you may be taking, and that there are guiding principles that are considered, where risks are identified, assessed, and minimized, and that the potential benefits are maximized, and also other considerations with pertaining to risks. That risks can be physical, that people can die or infected or lose the limb, psychological, that they can lead to depression, anxiety, and so on, or social, that if someone, for example, you're talking about HIV, if I volunteer to get tested, or if I develop HIV virus, if I am infected by HIV, human deficient virus, in getting tested, for example, COVID, that I am not socially discriminated by others, that I have AIDS, that is an important consideration also, or that I don't lose a job because of that. And economic, it could be a job loss, of course, because I'm participating in a certain study by a certain organization. So these need to be considered. And minimal risk refers to risk that is no more likely and not greater than that attached to routine medical or psychological examination, according to the WHO or CIOMS. So quickly, the way forward includes we talk about responsible research and innovation policy in European Union, and they framed the responsible innovation for health framework, where they said it must contain a collaborative endeavor wherein stakeholders are committed to clarify and meet a set of ethical, economic, social, and environmental principles values and requirements when they design, finance, produce, distribute, use, and discard socio-technical solutions and address the needs and challenges of health systems in a sustainable way. It's important for researchers, particularly, to appreciate such definitions. The reference article is down there, which was published in 2018, fairly recent, where they explain each of these keywords, what they mean by socio-technical, what they mean by environmental principles. Everything is explained properly. So they consider various value domains and definitions and define them probably with the right questions. And they actually drew out the framework where they say the organization, the process, and the product are within that scope. We have all these different realms that we need to see, the value domains and these dimensions that one need to consider through the innovation life cycle before they can form any kind of opinion or use the data in a responsible manner. So, well, I'll skip the 6 laws of technology, that they must be used only technological determinism, where they say we shape our tools and they in turn shape us. That is really important for us to understand. And the hype cycle and IoT, particularly in the context of IoT, I wanted to give this. There is what is called hype cycle, more about it can be read. Right now, emerging technologies are in that period of hype. Right now, we are still there. Later, there will be a disillusionment where there will be a drop, a dip, and then slowly a plateauing. That will happen eventually. But before that can happen, we need to form our policies that apply to wearable devices and IoT before IoT gets out of hand. And establishing trust in public consultation is really important. Crowdsourcing of information may be necessary. Ethical guidelines must be taken into consideration. Informed consent must be applicable. And making ethics as a part of the architecture by design is really necessary. You cannot simply impose ethics after you do everything. You have to build ground up. You have to pick your subjects accordingly, right? The ethical requirements say certain things. So it must be by design, ground up, organically built into the system. You cannot simply impose ethics. If you do your research first and then try to impose ethics, probably it won't ever pass any ethical review and does not come out. And new ontologies must be explored where you put the human first and not the technology, and not even the political or democratic system or anything. And there are private impact assessment methodologies that can be used. I'll skip Heidegger, but I'll suffice it to say that he says the purpose of technology is that it must bring form, function, material, form, function, and outcome together into one. And presencing, I'll talk about it later, but quickly speaking, presencing is to say that karma, we know the karma principle as Indians, of course, that what you do today has an implication tomorrow. So presencing is kind of a natural extension where they say they envision a better future for tomorrow and bring that future. What should you do today to get that best future? So what do you do to get to heaven is what we see in karma. Pretty much the same thing in presencing. And so he says technology is instrumental in the sense that it is a means to an end and not an end in itself. And it's an anthropological, which means it's a human activity. So you cannot really separate the subject and the human. The actor and the action are the one and the same. So you must ensure that the definition of technology also considers the humans. Enframing is what Heidegger uses, where you are enframing human beings in that technology. So it can get destructive. You need to take sure measures to avoid that. And well, art meets technology, I'll skip this. But also, as a matter of hope, we say, quoting German poet Holderlin, Heidegger says, but where the danger is, there grows also what says. So like I said, if we build an ethical framework, a responsible innovation for health in our own ways, we can probably build a better technology for tomorrow. So presencing and design thinking can actually have certain global goals, and we need to get those. And design thinking, quickly putting into picture, understanding problems from user perspective and implementing them that way actually makes things much better. And you can actually understand things from your people's perspective. When you're talking about a wearable and collecting data through a wearable in the application or in a research, you know what they may be concerned about. So you start with those concerns and ensure that you address those concerns in design before you actually make a product or make a solution. And trust, revisited, just wanted to make sure that in the context of this, we understand that cooperation, reciprocity, sharing of information, reliance, and confidence through credential exchange and accountability are all really important in healthcare research. With that, I end and I open up for questions. I'm sorry I overshot. I know it's into the lunch time, but I hope there was enough to learn. So the risk versus benefit ratio is probably fair, I hope. So can we take the questions now? I'm sorry I had to rush.
Yes, sir.
And
Thank you.
Contact information here for anyone to know. Yeah, so
So we have few questions.
sure.
Yeah, so this is the question. In the case of pandemic, frontline workers can be considered unequal compared to others, but otherwise, what exactly does treat us equally and unequal? Sorry, treat equals equally and unequals equally mean? How can we decide to prioritize the necessity of one person above the other?
Good question. Thank you. So I also in a passing remark, I gave the example of the reservation system. I'm not going to comment on the reservation system in its current form at all. Don't draw conclusions about what my stand is. But originally, it was intended to have reservation system in a country like India because the original drafters of the constitution identified that there are marginalized sections of society who need a better exposure, a better hand-holding, a better systemic support for them to be able to stand on their feet. That they were systemically oppressed for centuries. So, in order to bring them back into the fold, they had to be given better opportunities. And we are also talking about, I mean, while a lot of us probably have our own reservations about the reservation system, pun intended, we probably also hear all these specific women only schemes, women only jobs, women only resources available in research or all these things, right? We do that because we notice in a system that we do not have enough female representation. So that is a necessary requirement to treat unequals unequally. So, for example, tomorrow, if we realize that people with respiratory diseases have more risk towards COVID, I mean, this is already something we realize. So, after frontline workers, those are probably who must be treated unequally, so to say. They probably should get the vaccine sooner than the rest of us. Probably women who are vulnerable, probably children who may be vulnerable. That is how you look at it. So, unequals unequally means considering their conditions and situations, why they may be marginalized or left out of the mainstream system. So, that is the social, the qualitative research aspect that I didn't really get to touch upon through observational methods that you see, okay, these particular people are probably marginalized and they won't actually be benefited from this if we really go in a chronological order or some kind of standard alphabetical order. If they have to be benefited first, we'll probably give them a benefit first. So that is the unequally unequal part. I hope that clears.
Yes, sir, it does. So we are done with the questions.
There are 3 more questions I see on the Q&A thing.
Okay, do we?
How
we
to
were-
calculate processing time in fog computing? Honestly, Dr. Rajni Kumari, she posted it in Q&A. Dr. Rajni Kumari asked that question. Well, in fog computing, honestly, that is outside the subject that I am reviewing right now. But I would say the processing time or anything in the context of ethics must consider that you cannot really rush it. You could be doing it on the edge or using fog computing, but it must have enough time allowable for you to be gathering enough information ethically. That is the ethical context that I would bring into context here. And she also asked, are there any existing architecture for real-time? Oh, okay, sorry.
That was actually the last session's question.
Sorry. Yeah, sorry. That is what I just realized with the timestamp.
Yes.
Thank you. I'm sorry about that. I hope they got their answers in the previous sessions. So, any further questions? I do see at least one comment that said that there were good points. Thank you. I hope this can help everyone.
Thank you very much, Kiran sir, for spending your valuable time and enlightening all the participants about ethics. So it's really very useful to all the members. So, Darshan,
Yes, ma'am. So,
can you tell about virtual momento?
yes, ma'am. Sir,
Are
we
you able to
actually,
see that?
yes,
Yes.
ma'am, we are able to see.
Thank you.
Yeah. So, sir, we actually want to thank you for all the points you've told, and they were really insightful indeed. We were introduced to various concepts like VUCA and localization, which were new, and how these are important in adaptability and how one should always be ready to overcome these challenges. And thank you for enlightening us on how ethics, morals, and values are interconnected. And I'm sure most of the participants here would agree that the questions which were posted, I mean, you asked in the session, made us wait for a second and think made us think about technology from an ethical perspective, and not just from an ethical perspective of innovation, but also think about ethical innovation. While technology is all about practical application, as a researcher or a student who chooses to be ethical can obviously get better designs. So we would love to give you a token of gratitude. We want to present virtual memento.
Thank
Thank you,
you.
sir.
Thanks. It actually feels very special to receive this virtual memento. And yeah, that's something I would cherish. And I hope really people got the best benefit out of it and that they'll consider some of these. And for people who may not have gotten my contact information, I believe the organizers can give that later if anyone is interested. Please write back your questions if we didn't have time to ask them right here. Thank you everyone for patient hearing.
Thank you, sir.
And the organizers also, ma'am.
One information to all the participants. We are having session by Mr. Sridhar CB from 2 to 3:30. From 3:30 to 5, you are having performance by our Crescendo team live through WebEx as well as video streaming. And afterwards, you are having from 6:30 to 8:30 live demonstration of projects by 3 members. So it's very useful to all of you. Please don't miss the event. Use the same WebEx link. All of you attend from 6:30 to 8 p.m. today. Okay, first demonstration by Manu Satyasai. Afterwards, Narendra sir and Mr. Ramesh Reddy. You are having 3 demonstration by faculty members, and one of our alumni is also giving demonstration. So don't miss it. So please, all of you join for that. Thank you, Ananda.
Thank you,
Thank
everyone.
you, Kiran sir.
Thank you, ma'am. I thank all the organizers for putting up a great show. Sorry for the few minutes of delay and sorry for rushing out, but I hope
Okay, it's okay. Darshan, who are joining at 2 o'clock?
Yes, ma'am.
Who are joining at 2 o'clock?
2 o'clock we have Sadia who would be taking over the session.
Okay, no problem. Okay,
Yes,
so
ma'am.
please. Hello, Sridhar sir.
Hello, ma'am. Good afternoon, ma'am.
Good afternoon, sir. I will give rights as
Sure.
a presenter.
Okay, ma'am. Okay, so we will start at 2 p.m., right, ma'am?
Two, sir.
Okay, ma'am. Thank you.
Okay, thank you, sir.
Thank you, ma'am.
Ma'am, you're unmuted.
I am not there. I am taking food. చెప్పండి అలాగే సస్తాయి ఉన్నాయి బాబాయ్
మన ఫండ్స్
Ma'am, please.
కాలేజ్ అమౌంట్స్
కాలేజ్ అమౌంట్ ఇది చేస్తారు చెప్పమానండి ఏముంది అన్ని కూడా చేసేస్తారు
ఇన్కమ్ ట్యాక్స్ వెబ్సైట్ లో వాళ్ళ డేటా
ఫిల్ చేస్తే చేస్తారు
ఫిల్ చేసిన తర్వాత అక్కడి నుంచి
అది నాకు తెలుసు
ఈమె అరమంది
ఇక్కడి నుంచి చేస్తాడు ఏముంది అది వెబ్సైట్ అమ్మో డబ్బులతో విషయం నేను అది వేరే వాళ్ళు చెప్పి అసలు నేను గుర్తుపెట్టాను
Ma'am,
Please.
Ma'am, మీరు unmute అయ్యారు సార్.
ma'am, can we request you to mute yourself?
Yes.
Okay, ma'am. Thank you.
యాక్చువల్లీ ఐ థాట్ సారీ
Yes, ma'am, sure.
Ma'am, can we start now?
Praneeth? Praneeth?
Ma'am, did you add him as a panelist?
Yeah.
Yeah, I'm here.
Okay, Praneeth.
Praneeth? Praneeth, are you starting?
Yes, ma'am. Good afternoon, everyone. Our next session is on mobile to cloud computing for healthcare by Mr. C.V. Sridhar. Mr. Sridhar has done his BTech in ECE from JNTU Hyderabad and holds executive PGP from IIM Indore in strategic management. He is a part of the incubation team at TCS CTO Group and currently leads the CTO Incubation Alliance initiatives, working with ecosystem partners and startups for accelerating the incubation programs. Mr. Sridhar's current areas of work include developing solutions for drones, artificial intelligence, AR, VR, and rapid incubation programs. He has over 20 years of experience in areas like embedded systems, safety systems, IoT, AI performance engineering, and solutions for the government. He is now a part of Bureau of Indian Standards for IoT on the LITD 27 panel and heads the TCS Standards Forum for IoT-related technologies. He was the winner of Tata InnoVista, a group-level innovation event, for his work on smart farms using RF electronics. We are very honored to have you here with us, sir. Sir, we can't hear you.
Sir, please unmute.
I'm sorry. I'm speaking on mute. Yeah, good afternoon, everyone, and thank you, Praneeth, and thank you, ma'am, for giving me the opportunity to be part of this session. I'm audible, ma'am?
Yes, sir.
Okay, thank you. Yeah, so I'd like to thank the IEEE Hyderabad section, IEEE Signal Processing Society, and the IEEE Women in Engineering AG group for giving me the opportunity to talk at the IEEE SPS Summer School session. Would like to present a perspective of what TCS is doing in the healthcare. Would be broadly covering the areas of cloud and mobile applications that we are working on, along with the emerging technology trends that we're tracking and the areas that we're working on. So in the next 1 hour and 1.5 hours, we'll be walking through some of these things that TCS is working on, and would like to take few questions towards the end. With that, I'll share my presentation, and yeah, is my screen visible, ma'am?
Yes, sir.
Okay. Okay. Yep. Okay. So my name is Sridhar. I'm part of the CTO incubation team. So CTO is the corporate technology office at TCS, so which works on the emerging technologies and technologies that TCS has to focus over the next decade. We are the research and innovation arm for the software arm like TCS. TCS being a huge company, so we have a focused innovation group addressing all the technology needs that are going to come in future. The group is about 5,000 people plus organization with an investments of around $4 billion plus into the research and innovation. So our team is working in two main themes. So one is these are the research areas that we call. There are about 9 fundamental research focus areas. So ranging from deep learning and AI, life sciences, decision sciences, physical sciences, to the cybersecurity and privacy. So these are all technologies that we're tracking and have dedicated groups, a group of researchers working on these programs. And there are also a set of theme and outcome oriented programs that were defined in these focus areas where dedicated teams have been set up to work on the near term things. So when we look at a horizon of say 10 years, so we uh, right now, because the rate at which the technologies are changing, so we have to be so agile in terms of setting up rapid teams to address all these areas. And we place bets on all different kind of technologies, and many of them will be successful, and some of them will also will not go well with the market. So we address with this theme and outcome oriented research teams. Dedicated teams are set up for this one to address the innovation. Apart from this, we also have something called incubation, the group from which I come from, which is something similar to the entrepreneur in residence program. So where we are responsible for building startups within TCS. The areas that right now we are focusing are cognitive technologies, vision intelligence, the industry operations, and the rapid labs. So these are the four areas. So essentially, the group is formed to address uh, near-term technology wins. So where there's a good opportunity for commercialization with new technologies. So these groups will typically combine and form as business units. Eventually, I'll cover some of these things in the next few slides. So we also believe in collaborative innovation. So with this, we have a flagship program called TCS Co-Innovation Network. It's also called COIN. So what we do here is work very closely with a group of startups, venture capitalists, and engineering and entrepreneur in residence incubators across the world. So today we track about 2,000 startups roughly to see what is going on in these startups. And then we also work with 50 plus major universities. These are academic institutions where we collaborate with the faculty members there and the students, and we also run the hackathons in these universities to capture the talent and also work on all the research that is going on with academics in collaboration. And then we work with the alliance partners and industry bodies in terms of keeping abreast of all the technologies. At the same time, we contribute to them. For example, we contribute on the high level forum for 5G. We contribute on the Bureau of Indian Standards, multiple forums on Bureau of Indian Standards to define the guidelines and standards from the India perspective. And also the representation is there from the global perspective, TCS being a global organization. The customers are at the center of innovation, so which we think, so we while we're doing a lot of programs on a long-term basis for our customers, so we take the innovation that is coming up from all the ecosystems and then go and sit with the customers to address their business problems. So that's how we're structured. Some of the key technologies that we have focused teams again are the list that is on the right side. So these are the new technologies that are emerging. This landscape keeps changing, and these days it is changing very fast. So right now there are teams that are focusing on quantum, AI, machine learning, the multiple teams that are working on conversational interfaces and natural language processing, especially on Indian languages. Then we do have teams for machine vision, autonomous vehicles. Blockchain is a dedicated team for blockchain, but this is an example of technology that's been progressing slow. While there was a lot of hype across blockchain, but the technology is going a little slow than expected. A lot of things that are happening on the extended reality and cybersecurity is something that the external forces and the external threats are actually driving us to invest good amount of resources into cybersecurity, and I think it touches every domain. Cloud and omni-channel solutions. Again, TCS works for multiple verticals like retail and other things, where these are the solutions that are critical. The digital platforms and enablement. So any customer is now looking at getting their digital transformation journeys, and because of the COVID, it has accelerated a lot. So the dedicated teams are set up to work on these kind of themes. When it comes to incubation is a sub-organization under the Corporate Technology Office, essentially focusing on technologies that are very, very close to commercialization. So a lot of these technologies have got a long horizon in terms of getting to the market. So a lot of time these technologies are in the research mode at academic level. But there are technologies that are very close to commercialization, and there's an immediate need for TCS to build solutions around these things and engineer them with reliability and take them to the customers. So the group focuses on building such technologies. So the team goes for about 18 months to 36 months, after which the solutions are built and handed over to one of the business verticals within TCS. The goal is again to develop things faster than the industry. When we say industry, it is the software and IT services in general. Startups sometimes are typically faster and agile. Again, growing with the collaborative innovation. So we go with both internal, external partnerships, and we believe in mutual collaboration. So we help a lot of startups across the world in terms of taking these technologies as a consumer or exposing these consumers as one of the market forces. So we take these sort of startup solutions, which we believe are good to the market ourselves. We have set up platforms where we enable startups can publish their solutions. So startups can come with their ideas and then publish it to us on a TCS platform like Cubo, which is an API platform where they can directly reach customers of TCS. So we choose very diverse and high